Welcome to AETCM, the Emergency Medicine Channel. Specialist.
Yes.
A 38-year-old male, known case of type 1 diabetes, presented to the ER with complaints of abdominal pain and vomiting of 1 day duration. On our initial 10-second assessment, the patient was conscious, oriented, and obeying commands. Coming to airway appears patent, no secretions. Breathing air entry bilaterally equal with a respiratory rate of 23 per minute, saturation of 98% on room air. Coming to circulation, BP of 110/70 millimeters of mercury, pulse rate of 100 beats per minute. 2 large bore IV cannulas were inserted during this point of time. Coming to disability, GCS of E4, V5, M6, pupil bilaterally equally reacting to light. Coming to exposure, temperature of 99.5 degree Fahrenheit with a GRBS of 450 milligram per deciliter. Coming to adjuncts of primary survey, we taken a VBG which showed a pH of 7.23, bicarb of 14, PCO2 of 28, sugars of 450, potassium of 4.6, sodium of 123, which suggests a high anion gap metabolic acidosis.
Okay.
We also taken an ECG which showed sinus tachycardia.
When you tell about high blood sugar with sodium, corrected sodium is always important.
Yes.
Why?
Because it indicates dehydration, sir. It's a osmotically active solute, sir.
When sugars are very high, what happens to serum sodium?
Decreases.
It falsely decreases. Patient is having actual normal pseudohyponatremia occurs. But a patient who is having DKA or suspected DKA, if the sugars are normal or near normal, what is your diagnosis? What is your diagnosis? And there is always an element of HHS. Okay. So HHS and DKA can be coexistent. Sometimes sodium, if it is normal in DKA, you have to always suspect a HHS. That is a very important thing. Okay. Here it is low, then you have to do a correction of the sodium. You will get actual value.
We have calculated the corrected sodium, sir. Can be calculated in 2 ways. One by the formula, we have calculated the corresponding sodium plus 1.6 into glucose minus 100 divided by 100.
Okay.
Or we can calculate like for every 100 increase in glucose, the corresponding sodium will increase by 2. So the corrected sodium comes out to be 129. Sir.
Okay.
We have taken ECG that was showing sinus tachycardia.
Okay.
Coming to sample history, a 38-year-old male, known case of type 1 diabetes on insulin, presented to the ER with complaints of abdominal pain and vomiting. The abdominal pain was mainly on the epigastric region, no radiation, no postal variation, no aggravating or relieving factors.
Okay. What is the main difference between type 1 and type 2?
Type 1 is autoimmune destruction of the pancreas where there is absolute deficiency of insulin.
Insulinopenia is seen in type 1.
But type 2 diabetes is insulin resistance. Plus
Predominantly insulin resistance. Some patients can have insulin deficiency also. Okay.
Abdominal pain, epigastric region, no radiation, no aggravating.
The patient is having abdominal pain in the epigastric region. What is your first differential diagnosis?
Pancreatitis.
Pancreatitis. In DKA? DKA as such can have abdominal pain. So it can mimic pancreatitis. Only thing is DKA amylase will be raised. In pancreatitis, amylase and lipase will be raised. So you are supposed to do both the investigation to rule out pancreatitis.
The patient also gives history of vomiting 4 episodes. Non-projectile contains food particles. The patient also gives history of skipped insulin doses for the past 2 days.
No what happens to the intestinal motility in DKA? Why they vomit? Intestinal motility.
Decreases.
Motility reduces. Especially in diabetes itself, it is reduced. DKA, it is further reduced because of hypokalemia. Okay.
No history of any chest pain, palpitation, loose stools, abdominal distension or obstipation. No history of any muscle weakness, altered behavior, any food intake from outside. No history of any allergies. On medication history, the patient is on injection human atrapid 20-010. No history of any similar episodes in the past. The last meal was taken at 8 a.m. Coming to examination.
When you go to ICU, this 20-010 is okay or it is not okay? Is it ideal or not ideal? Atrapid is short-acting insulin. When the patient is admitted in ICU, can you continue this type of insulin regimes?
No, so the demand will be
Demand will be high, but can you continue this type of regimes?
No, we can monitor according to the GRBS and
That is old method, sliding scale. That is not used nowadays. Short-acting insulins are always short-acting. It acts only for 6 hours. A patient admitted in ICU, they require more frequent doses, at least 3 times daily, just before the meal. This 2 times dose is not good for a normal person. Somebody is having a renal failure, that is okay.
Coming to examination, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, chest clear, air entry bilaterally equal, CVS S1, S2 present, no murmurs, GIT abdomen was distended, soft and bowel sounds were present. Coming to CNS examination, GCS was 15/15, bilateral pupil equally reacting to lights. Our initial impression was a hyperglycemic state, probably DKA, which was precipitated by a skipped insulin dose. At this point of time, we have put 2 large bore IV cannulas and we have taken the routine samples including serum, ketones and amylase and lipase. We also did a bedside echo to assess the hydration status. We have checked the IVC and it was showing a Caval index of more than 50%. Okay. And we also checked the LV showing good LV functions. So we started the patient on the mainstay of treatment of DK. We can under 3 headings we can categorize. One is IV fluids, second comes the potassium correction, and finally the...
So what are the deficits in DK? If you know the deficits, it will be easy to treat the patient.
One is fluid deficits.
The most important is fluid deficit of fluid. How many liters are deficit here?
8 to 10 liters.
Okay. It is lesser than HHS. 8 to 10 is HHS. Here it is 6 to 8. Okay. But treatment wise, it may not be big thing for a ER physician. One is fluid. Why fluid is lost in DKA?
Due to hyperglycemia, there will be osmotic diuresis and there will be
okay. Loss. So osmotic diuresis and patient loses in DKA, whereas in HHS, most of the time HHS are occurring in elderly individual. Either they are not taking proper they are not taken care properly, or like in DKA also, patient is losing volume through the urine. Anyway, the volume deficit is the number 1 problem. Second problem is?
Second is potassium.
Potassium deficit. What is the cause for potassium deficit?
The transcellular shift of potassium.
High blood sugar shift the potassium. Then you start on insulin, that also shift the potassium. So potassium deficiency is already there, and suddenly it can even shift after starting of the insulin. So that is the second problem. Third problem is?
Sugars, high sugars.
Ketone bodies. High sugars can produce ketone bodies. How do it produce ketone bodies?
So in DK, the pathophysiology is like there is absolute severe insulin deficiency with counter-regulatory hormone excess.
Okay. Coming to the counter-regulatory
glucagons. Okay. And coming to the biochemistry level, we can say like that there is a hyperglycemic state. Okay. Due to absolute insulin deficiency, there is hyperglycemic state. But the glucose cannot be utilized by the organs because the GLUT4, which is insulin dependent. Okay. So in case of insulin deficiency, the GLUT4 cannot be functioning and take the glucose inside. Okay. So as a result, even though hyperglycemia, the body
cannot utilize
glucose, and there will be gluconeogenesis initially, and that will use up the oxaloacetic acid. And another function of insulin is like insulin inhibit the hormone sensitive lipase. Okay. In the absence of insulin, the hormone sensitive lipase is overexpressed. As a result, the triacylglycerol will be converted into fatty acid and glycerol will be converted. Okay. And the fatty acid then converted into acyl-CoA. And acyl-CoA comes to the mitochondria and converts to acetyl-CoA for beta oxidation of fatty acid. Okay. But that takes place only in the presence of carnitine palmitoyl transferase 1. That is expressed only when there is a counter-regulatory hormone excess, that is decreased insulin and increased glucagon. So only when there is a counter-regulatory hormone excess, the CPT1 is expressed on the outer mitochondrial membrane, and the acyl-CoA comes to the mitochondria for fatty acid, beta oxidation of fatty acid. Okay. And after this beta oxidation of fatty acid, it has 2 pathways. One go to the TCA cycle or go for ketone body synthesis. But initially for the gluconeogenesis, we have utilized the oxaloacetic acid, so the pathway for TCA cycle is closed. So the only option there is ketone body synthesis. So there is ketone body synthesis.
Okay. So ketone bodies are produced here and ketoacidosis occurs. But you also should know that there are other reasons for ketone body production in a diabetic patient. What are the other reasons? Other reasons for ketone body production in a diabetic patient, other reasons other than DKA. Starvation. Patient is not taking anything, ketone bodies. Pregnant lady, ketone bodies can be produced. So there are other reasons for hyperketonemia, but that may not produce ketoacidosis. And there are other reasons for acidosis in diabetic patients. That also mimics same thing. If you don't have facility to test the ketone bodies in blood, you will have to wait and watch what will happen to the patient. So what are the other reasons for acidosis in diabetic patients?
Lactic acidosis.
One is lactic acidosis. Then renal failure can produce acidosis. Liver failure can produce acidosis. One of the most common cause in our state is alcohol. So you get many patients who consumes alcohol, whether it is normal alcohol or toxic alcohol. That also can produce acidosis. So you have to keep all these things in mind. Sometimes dual acid-base disorder can be there. One, you have ketoacidosis, other one, patient can have alcohol-induced acidosis. Both are possible. So you have to be very careful when you are treating ketoacidosis. Okay.
Then we assess the dehydration status, sir, and we divide into mild, moderate, and severe.
Okay.
And we look at the IVC and the LV function, and we have to give a rapid administration of fluids initially.
Okay.
We follow the different guidelines are available. We follow the Indian Endocrine Society guidelines, which says that 250 to 500 ml per hour fluid should be administered, and frequently you have to monitor the output, or you have to check it.
So there are a lot of guidelines which says first hour 1 liter, first hour 250 liter, 250 ml, 500 ml. There are a lot of guidelines. But what we should understand is rapid reduction of sugar should be avoided. How fluid produces rapid reduction in sugar?
It is correct, the dehydration. That itself will decrease.
That is the most important. So when the blood is concentrated, sugar value is very high. You add water, it will immediately dilute the sugar. So the drop in sugar is very important. What is the expected drop in sugar?
10% decrease in the...
Okay. Hourly, at least 75 to 100. That is 10%. 75 to 100 only. That's all allowed. If you do it very fast, what will happen?
Can lead to cerebral edema.
So avoid that. When you give fluid itself, sugar will start coming down. So like you told, there are different guidelines. Some guidelines 250 ml 2 liters per hour. Some guidelines say only 1 liter initially, then another 1 liter. Then over 24 hours you correct rest of the 4 liters. Okay. Whatever way you can correct, but only thing is sugar should not be dropped very fast. When you are giving fluid, you have to monitor the patient. Patient should not go to pulmonary edema. Okay. These are two things you should remember. One of the reason for that is diastolic dysfunction. What is diastolic dysfunction and fluid challenge?
Fluid.
You are giving fluid, 500 ml of fluid to a normal person. He may accept it. But a person who is having diastolic dysfunction, especially in diabetes, what happened to the patient? So whatever told in books, you give fluid, continuously give fluid. But a person who is having diastolic dysfunction, how he is going to take that?
The load will still be increased, sir.
The diastolic dysfunction is heart is not taking the blood. So patient will definitely go to volume overload and he may go to pulmonary edema. So that we have to remember. So depending on the clinical scenario, slight modification is required. That's why you have to monitor the patient. So fluid is given. Next is what?
Next is potassium corrections.
Okay.
Potassium correction, that also various societies have different guidelines. As per the Endocrine Society India, less than 3.3 is the potassium level.
Okay.
Then we should not start the insulin. You have to first correct the potassium.
Okay.
And if the potassium is between 3.3 to 5.2, then you can start fluids, and also by the meantime you have to add a small correction of potassium.
Okay.
And it is more than 5.2, you need not wait. We can fluids and insulin.
So can you get a patient who is having DKA with high potassium? Where will he get?
Renal failure.
Renal failure. That is one of the common presentation we have. High blood sugar, kidney failure, hyperkalemia. That type of patients, you no need to wait for your potassium. You can directly start insulin. What happened to potassium if you are starting insulin?
The
transcellular shift will occur. It's a good thing for the patient. Okay. Otherwise, potassium should be corrected. How do you correct potassium? Suppose it is 2 in this patient. What will be the total deficit in patient?
For every 0.3 deficit corresponds to 100 milliequivalents.
100 milliequivalents. Suppose it is 2. Then how much is the deficit? 0.3 is 100.
500, at least 500 milli.
500 milligrams. How do you correct it?
You can correct through the central line. It
So then you have to put a central line only. That's all we can do. If you give through peripheral line, definitely patient develop all thrombophlebitis and other problems. So then you have to put a central line. Otherwise, central lines are not required in management of DKA. Okay. So you give potassium if it is low.
And then third comes the insulin infusions.
Okay. How do you start insulin infusion?
There are two ways of starting. One is by starting as giving a bolus dose and then continuing as infusion, or directly continuous as infusion.
Which is beneficial?
Ideally, we follow the Delta protocol. That is, we started as an infusion via.
So both are same. There is no advantage over bolus dose or infusion. That's why we all continue infusion. But if we want to give bolus, that's also okay. There is no contraindication for that. How do you select type of insulin? What are the insulins can be given during acute phase?
Usually we are giving regular insulins.
Okay, all types of short-acting drugs, whether it is analog insulin or regular, normal, what is that, conventional insulin, both are same. Okay, what is the difference between normal insulin and analog insulin? Normal insulin is what we are giving is Actrapid. It's a brand name. That is a regular insulin, human regular insulin. Other one is analog insulins, which are costly insulin. What is the difference? Can we give analog insulin instead of regular insulin? Fast acting analog insulin, fast acting regular insulin. What is the difference?
Unless we can overcome the resistance.
What is that cause for resistance? When you are giving human insulin for a long time, there will be antibodies produced against that human protein. Okay. When you are giving a analog insulin, that is artificially created. There is no antibodies against them. So the requirement of insulin will be only low in your regular analog insulin, but whereas in other conditions, requirement will be very high because of the resistance. That's the only thing you should remember. If the patient is already on analog insulin, you can continue that analog insulin as your infusion protocol. No need to change your regular insulin what you have. Okay, that is the only thing.
Then we will continue with the infusion, and then we will monitor the GRBS hourly, and we will stop the insulin infusion only if the indications are there. One, the patient should attain the normal appetite, the acidosis should be corrected.
Okay. So when the sugars are around 200, 250, what change you make in your IV infusion? IV fluid infusion?
We can start with DNS. If the serum ketone is still present, acidosis, everything still present, then we can start with DNS, and we need to maintain a target of around 200 in the case of DKA and 250 to 300 in the case of HHS.
Okay. Why it is like that? Why we should change to DNS?
Otherwise the patient will go into hypoglycemia.
That is in adult. Children? Child, the reason is different. Adult, what you told is correct. Patient can anytime go to hypoglycemia. Child, it is rapid reduction from 250 onwards. They can develop brain edema. So to prevent that, in children we have to be very careful. Adult, it's okay. Only hypoglycemia is the major problem. The brain edema is not very much documented in adult. Okay. So that we have to change. Then when will you? How long you continue insulin infusion in your ICU?
Once the patient attains a normal appetite and the acidosis is corrected, the anion gap is closed.
The answer is acidosis. Once the anion gap closes and ketone bodies are completely negative, anytime you can switch to your conventional insulin regimes. Otherwise, you should not stop it. You have to continue it. If you stop suddenly, what will happen? What it is called as? Rebound DKA. Anytime patient can redevelop DKA. That doesn't require like high blood sugar. What blood sugar DKA can present? From what blood
more
sugar?
Than 200 to 250.
More than 250 you can develop again DKA. So should not stop it suddenly. How do you stop it? Insulin infusion in ICU?
Once the serum ketones become negative, acidosis is corrected, then we will calculate the last 24-hour insulin requirement will be calculated, and approximately 30%, 1/3 we will give as bolus dose, and the next 2/3 we will giving in.
So you divide into total dose divided into 1/3 and 2/3. And initially you can give 1/3, then 2/3 can be given afterwards.
Continue infusion for 1 more hour.
Okay. So when you are switching to regular insulin, like you are continuously giving infusion, you want to switch to subcutaneous insulin, you want to select long-acting insulin or short-acting insulin. As far as patient is in your ICU, short-acting insulins are the best. Long-acting insulin, once you give, it is already given. Patient can go to hypoglycemia. So to avoid that, all drugs in ICU should be short-acting, whether it is antihypertensive and anti-epileptic or insulin, everything should be short-acting in ICU. Once the patient go to ward, then you can switch to long-acting insulin. So you are giving same dose of short-acting insulin as a BD dose or TID dose. Ideally, it is TID dose, or sometimes some patient may require 5 times, 6 times short frequent interval, especially in pregnant ladies. They require short frequent doses. Then you want to switch to long-acting insulin. How do you switch? That's all happens only in ICU. How do you switch it? You are giving 30 units TID regular insulin. You want to switch it to a long-acting mix acting, like 70% long acting, 30% regular acting insulin. Currently you are giving 90 units 3 times. That means 30, 30, 30. How do you switch?
You have to give like 70% of the total.
That is so 2/3 is enough then. 90 means 60 is enough. See, in that 60, 40 will be in the morning, 20 will be in the night. Like that you can give, or you can select a different type of regime. Morning and afternoon you can give regular insulin. Night you can give a long-acting insulin or ultra-long-acting insulin. That all possible. That all depends on the clinician's experience. Okay, so that any type of regime you can select. There is no issue. So when will you select 50-50 insulin? When will you select 30-70 insulin? So there are preparation. One is 30-70 or 25-75. Other preparation is 50-50. 50 short-acting, 50 long-acting. When will you select that?
Postprandial
If somebody in your ICU eating well, he is eating lot of food, his postprandial sugar will be very high. In that type of patients, you have to give 50-50 insulin. Very rarely we come across such situation. But there you have to give 50-50 insulin. Otherwise, normal patients require only 30-70 or 25-75. Okay, that is required. Okay. So then other than that, what all things you do in your ICU for supportive therapy? So a patient is admitted for DKA. What all supportive therapy you give to the patient?
We need to mobilize the patient.
Okay, mobilization, early mobilization is always better because they have a high chance of DVT. Okay, then you have to rule out infection. If there is infection, you have to treat the infection. What are the electrolytes important in ICU for DKA patient? What are the deficits in electrolytes?
One is potassium.
Potassium is the most important electrolyte that we have to correct.
Magnesium.
Magnesium is very important. What is the importance of magnesium in DKA?
Magnesium helps in the intake of glucose.
Insulin to the cells. Okay. So magnesium is very important. Then phosphorus is very important. Calcium is very important. Vitamin D is very important. All these things we have to correct. And most important thing is rule out some infection, rule out some infarction. Myocardial infarction, stroke, all these things are possible. What happened to this patient afterwards?
We have the serum ketones became negative, and we have started the patient on.
When you talk about serum ketones, some hospitals will have only urine ketones. What is the difference between urine ketone and
urine ketones will be still positive. Even if the acidosis is corrected, urine ketones
will be positive for many days. That is a problem. But serum ketone, once it is negative, it is always negative. So that you can depend mainly on the serum ketone, but some hospital may not have this serum ketone estimation. In that case, you have to go for urine ketones. Okay. What happened to the patient afterwards?
We have calculated the insulin requirement. It was coming around 30 units.
Okay.
So we initially give 1/3 as a bolus dose and 2/3 in divided doses.
Okay.
We monitor and we adjusted the insulin accordingly, and the patient was in a state DKA completely resolved and not going into hypoglycemia, completely maintaining the algorithm. And we discharged the patient.
Okay. No other issues are there.
No issues.
Anything else? That's all. Okay. Thank you.